bigger may come up. I don't want to say anything more than you brought there. But something bigger may come up. Are you going to carry the work with it? So you also all the parastatals. And we're going to start a quality assurance program from 25th of September to the resource person from Latin Hospital. We're going to look at how we can get accreditation for our health facilities. Things like JNCI accreditation, the South African accreditation, accreditation and to be a health facility with high level of quality care if we have these health workers. I hope you understand. So if we can get just that right, I can tell you we'll turn around the health services. So the tactics, the approaches are all the things that we said before. Carry out research, have your data, do monitoring and evaluation. And then the training question, process evaluation. That's an evaluation. And then this involves process evaluation. Number of health workers trained in emergency or health care. Number of every treatment and drugs supply. When you ask for outcomes, evaluation assesses the outcome of the particular intervention. It looks for long-term effects or consequences. It's a complex area because of the time between multiple outcomes. It's using indicators such as number of maternal deaths, maternal mortality ratio, or number of obstetric complications. So you see whether maternal mortality ratio, what type of indicator is this process or outcome? Is outcome. And then number of home programs is process. Now we have these indicators.
Yes, I'm not hearing well. Mo láti gbé sí etí mi kí n tó máa gbọ́. Nísìnyí mi ti ẹ̀ gbọ́ mọ́. don't know how to use this one.
No, it's your volume. Where's volume? It's at maximum.
Yes.
It's not your fault.
Kí n pè ní ìdí èmi tèmi wọ̀? Mi ò mọ.
You are
Ita ana ruwa ne.
Baya ne.
Yana yi.
To ba za ki ji ba.
Akwai some network problems. Wannan abun kawai ya not yet right for it wallahi.
It's perfect.
They have a place there in the suke amma zan je kawai in zauna.
Have a place suna me.
A hotel din suna da wurin ne wurin akwai kaman center inda su ma presenting suna
People are welcome to come. In kashe ne?
ya kashe. Bari ya ɗan yi caji. Itace mai caji.
Ita kuma me ta yi wani?
To ba za ta wayanta din
ba ta da data ne.
Ba ina gani wayan ne kawai ba ya ba zai yi mata cajin ba zai zauna da yi ba kuma a ci ba internet.
So success stories. When our present governor was honorary commissioner for during the state I didn't believe it. He said it's going to happen. He said the way your team came and pestered the commissioner for works and the entire ministry, they had never seen such an aggressive team that they had no option but to give us what we wanted. And shortly after the vote was prepared, the new administration of Wanga came in. And the first program of Her Excellency was to organize free eye surgery in that hospital. When I went to partake in that program and I saw the cars lined up on the newly repaired road, I said, advocacy works. We also advocated legislators from cholera areas to build their clinics, and they did, and that's all the outbreaks, and so on and so forth. So, what can doctors and health workers advocate for? You can ask for offices with relevant office equipment, including computers linked to the internet, so that even when you're not consulting, you can be doing your research. The fact that many times people complain doctors are not around. The issue is when they finish the work down, there's still nowhere for them to have. They can't be hanging around the corridors like people that have nothing. Well, if they have an office where they can do their research, it helps. I can't remember which event I went to or which course I went to, but we were told that one of the reasons why they have a lot of Nobel Prizes from the University of Cambridge is because they have this long corridor that leads to their TV. So most times, as people come out to go through the corridor, they bump into each other, and as they bump, they start talking about ideas. So that interaction, having that enabling environment where you can talk with colleagues, a situation where you are the only cardiologist in the hospital is not helpful, because you need to have others to discuss with. Though now with telemedicine, you can improve it, but it's still good to have people. So that enabling environment. Having departmental secretaries and administrative assistants to help you with your referrals, with your medical reports, having houses, relevant special equipment, HPG vaccination, scheme of service for doctors and health workers with diplomas and masters. I remember those who have masters in public health and diplomas in anesthesia approach me and say, we will not give us scheme of service. You're just giving us a scheme of service as if we're just MBBS. We are above MBBS, and yet we're not consultants and so on. And I said, put on the decision paper, and they were just looking at me, and they were just looking at me. I said, don't forget that. I think you are worried about other people to say, but I'm push for it. Please, because of COVID-19, never really if one highly organized so I don't use things that that we should use following the things. So that when you see this one, you don't allow children to come here. If it's that, so I don't use that. I use that. And we should use it following things. So when you see this one, you don't allow children to come here. If it's that, that's wrong. I don't understand. And when I remember when I went to one year in some location, and I was and said, where do you go? I don't understand. I said, you don't do that in civil service. I said, somebody answer you. My sisters, there are so many things you can get through advocacy. And when you learn how to ask in a strategic manner, you will never go on strike. So internal advocacy, sometimes we give stakeholders a long list of things we want them to do. It's also beneficial to give ourselves a list we should do in that internal advocacy. Appropriate use of computers. Look at Zoom now. Any medical woman that does not know how to use Zoom, I will give you a medical query. Because by the time the lockdown came on and everybody was now organizing these meetings, it's my children that taught me how to use Zoom because they were using it for their online university courses. I said, I have to learn because I don't want to be left behind. So I had to keep learning until I was able to host a meeting. Now I also have license to host meetings. Center management, we'll talk about that tomorrow. The way we run away from data is painful. Look at COVID. Before we could even to get data, it was hard. Self-auditing, reducing waiting times. Can we come up with a plan to make sure that we don't have more than 20 people in OPD waiting at any time? When we went to Japan, they took us around one of these state-of-the-art hospitals, and they said they see 900 patients a day. They said, but they are not patients waiting. They said they see them on appointments. They have about 20 or so consulting rooms, and they are giving them appointments. So if you come, you're not going to wait more than 20 minutes. So you don't see crowd. We can do it. We just need to make up our mind. Better utilization of training. That's why we are doing the quiz. All the capacity building we have had this year, we want to see how much we really check. So please collect your CDs, go onto the website to get the materials, and so on. So internal advocacy is required for us to commit to the volume. We should see ourselves as brothers and sisters. Some of us, health workers, doctors, have behaved abominably to their fellow colleagues for selfish purposes. We need a united front to address many of our challenges, especially the external one. And there should be mentoring or sharing of knowledge opportunities. So for everyone, about an advocate, you are not just a clinician, you are also an advocate as a health worker, as a doctor. Advocate for issues that will provide an inclusive environment. Don't sit there and say, why can't government say, how do I advocate for government to get this done? If you don't know how to do it, ask those who know. It's not expertise, but more importantly, practice, time, determination, passion. We need advocacy and lobbying. So that we don't need for doctors and health workers to go on strike to press this. We also need a human advocacy for mental health education. Advocacy work. Let's all give it to them. So before that, we have advocacy is not part of the function of medical and health practitioner course. Advocacy can only be done through writing of letters to government bodies for course. Smart objectives are necessary for advocacy to be successful. True. Adversaries are important stakeholders in advocacy. Successful advocacy messages should balance facts with emotions and human stories. True. Effective advocacy activities are usually one-off events. False. Maternal mortality ratio is a process indicator for evaluating advocacy activities. False. Number of HIV awareness campaigns organized is an outcome indicator for evaluating advocacy activities. False. Effective advocacy can reduce the need for strikes by Nigerian doctors and health workers. True. Internal advocacy among medical and health practitioners will improve quality of health services. True. Thank you for after all the presentations, we take questions. So can we have the next one? When are we having your exhibition?
After the second one.
Thank you very much.
Hello. We're going to show you the but put her on as post. She's sharing her slides.
Well done.
Well done. Medical women, well done.
How many participants do we have?
We have 57.
Very few were going in and out, but the complaint was of audio and all that. So I don't know if
better now. It's going to be better with those who are
that are doing straight.
I will find out from Mr. Dr. Effect. You can stop.
This one will change. I can't even do anything. I cannot do anything. Even I.
So if you want to retire for the rest of the year, So 17 states. That's more than a more than now your batch.
Good morning, everyone. Can you hear me, please?
Yes, we can, ma.
Okay, good morning, my teachers, my friends, Medical Women Association of Nigeria. I'd like to thank the president
5 years now.
for this presentation.
I'll be 4 or 5 years.
On development and use of information, education and communication materials.
Support, yes. So yeah, I take over. I take over. I will take over in October. Diamond, the pen I Hanover, But I'm not going to tell them about a guy for it. I did go your tail like so I'm going to find me bottom, then bomb anytime I mean I'm bottom. Anytime, maybe I'm working for young one. I need to come in but
Can we mute the other people? I can hear other conversation. And okay, so we'll start with the definition of information, education, and communication. Information can be defined as the content of the message. Education is a systematic training for the development of mental power and character. So instructions are given to increase the knowledge and abilities of the person you are giving the education to. Communication is when you share information and also disseminate information. So looking at all of them together, information, education, and communication is an approach which attempts to change or reinforce a set of behaviors in target audience regarding a specific problem in a predefined period of time. This was defined by WHO. So you have to have something in mind you want to educate someone about. You have to have a specific target in mind. You have to set a specific time period in which you want this information to be disseminated. So what are the scopes of IEC? First is to change the health behavior of individuals, family, or community. So that is one of the reasons why anyone will want to embark on information, education, and communication. To facilitate public health education for a specific audience and to create awareness in public opinions. We also want to increase the utilization of a health service or improve quality of a service. So let's say you have like a new public health care center, primary health care center, and you want people to utilize their services, you can go and institute an IEC to just intimate people that you have such services available. We also use IEC to gather social and political support for health services. You know that it's the politicians that actually stamp things, they make things work. So to be able to garner the support, you need to educate people about what they need so that they can go to their constituent and ask for this. To prevent and control infectious diseases, we've seen a lot of this in play during this COVID era, and to ensure feedback mechanism, this is very important. So what are the ICT questions? What questions do you need to ask? It's similar like you want to you want to do a research, you have research questions. So you must have an IEC question. So who are the target audience? Are they opinion leaders, teachers, undergraduates, male and female, in and out of school, adolescents, community health extension workers, pharmacy operators, just name it, even doctors? Who are those that you want to target? And then what do they already know about this information? What information gap exists? What other information is now available that you want them to know? What are the issues surrounding this information? So like environmental factors, for instance, we know that poverty is one of them, that adolescent mothers have difficulty supporting themselves and sometimes enter into sexual relationship for support. So we have unemployment, we have high cost of marriage, negative roles, lack of positive role models. These are examples of issues surrounding adolescent reproductive and sexual health. So these are
I'm
the
actually
issues
with
to look at concerning.
no.
Then what scope do you wish to cover? Do you want to change the behavior of individuals, the family or community? You want to facilitate, just basically what are of this scope. Remember that you can't pick all, just pick one that you want to do. So which materials you want to use? These are questions you need to ask yourself. And then how effective are these materials? So what are the set objectives? For example, using the adolescent reproductive health set of objectives, you could say that in 5 months of distributing posters, you want child labor to have reduced by 90%. So that's a set objective. Or 4 months after the distribution and use of home videos, you want 80% in and out of school adolescents to have been making use of sexual and reproductive health counseling services, provided that such services are available and they are accessible to the adolescents at no cost. Or you could say that at the end of a radio broadcast, the number of adolescent pregnancy, unsafe abortions, and unwed mothers would have reduced by 70%. So what are the steps in developing IEC material? So you need to conduct a needs assessment and set a goal. You have to establish behavioral objectives that will contribute to achieving this goal. You need to identify potential barriers and ways to overcome them. There's always problem here and there. So you need to envisage these problems and how you want to overcome them. Then you now go ahead and design, produce, and pre-test the IEC material or activity. Then you want to implement and document activity. You want to monitor and evaluate and make sure that you are actually reaching the people. So using the Laxwell's method, this was developed, I think, in the early 90s, where you have a model for how you want to effectively communicate. So first of all, you have who is sending this, who is this information coming from? Is it somebody that people will listen to? That is also very important. You don't just wake up and want to send a message. You must know, is it the person that do people listen to this sets of individuals? You want to say what is the content of the message? What exactly do you want to say? And in which channel do you want to, or medium do you want to do this? Do you want to use poster? Do you want to use television? Do you want to use radio? Then to whom? So who is the receiver? Who is your target audience? You also have to have that in mind. And then with what effect? That's the feedback. It's usually a two-way system. You don't just give information, you must be sure that that information you've given, people have received it, and what is their reaction to this message that you have given. So then let's look at them one by one. So you have to select appropriate material. So you have different types of IEC material, which we are going to discuss later, but you need to look at their strengths and weaknesses. What is the strength of this particular type of medium you want to use? Is it going to effectively give your information? How compatible is your message, the content of your message, with this type of material that you've selected? What is the cost of production? Nothing is free. You need to look at your budget and make sure that what you've chosen, your money can cover it. And then the distribution wise, there's no point using high-tech things in a rural area when you know that people cannot have access to it. So those are the things that need to be looked into. Then your audience, what are their preferences? What are their characteristics? What do they prefer? You know, there are some places that they don't watch TV, they prefer radio. There are some places that, of course, they don't have access to internet. So you know how to make your information accessible. And what is their literacy level? There are some people that can't speak English. So what are you going to use to be able to give your message appropriately? What's the attitude and the stage of behavioral change you want to ensure? So those are the things you think about. Then you observe the setting in which this will be used. Is it where people will receive it well? Is there any problems that would arise, whether cultural wise, religious wise? You have to look at that. Then the media survey, you need to know how wide is this media, how wide you want it to be distributed. So we need to, so for the step 2, you develop a creative brief. This is important because this is the gap between the development team and the creative team. So in this creative brief, you decide what exactly you want to do. Or you adopt an existing material and consider the following. Does this selected material fit the audience? Does the material reveal the objectives? Those are important. So let's say you're adopting an existing material, you have to look at this. If you're preparing a draft, you have to look at this. If there are visuals involved, do they have factual discrepancies in the visual that can lead to misinterpretation? Do they emphasize, enhance, or clarify important points? And are they easy to understand, or do they rely heavily on the text to convey important meaning? So those are very important. So for especially that people should not misinterpret um, your message. Then what is the approach? Will the visual convey fear, anxiety, or encouragement? It's usually better to portray encouragement, to relay anxiety and fear. If your message is going to have a fear component, you should be prepared for the consequences. How do you hope to combat this? Are they culturally appropriate? Is the tone harsh or is the tone harsh or condemning? This is so important. Are the materials well directed to the target population? So so for the step 4, you pre-test this draft IEC material. You have to test it to determine that there are no gaps, that it's clear, it's attractive. You look at the sensitivity of the message, how useful is it? Is it directed to the audience, or is it induce an action? So IEC material should make one to induce an action. It should not, there should be a response from the materials that you are giving out. So the pretesting is done usually on a representative members of the target audience, and then you ensure that with this step that you capture the audience perspective. So If during the preparation you didn't look at the audience, the target audience perspective, this is the period to do that. You get advice on how you can modify your words or the pictures or whatever you are doing. So for the step 5, you now assess your results. Okay, it's usually advised that it is safe to assume that if 70% of the target audience considers the message, they would, if they consider that they will undertake the recommended actions, if they find the IEC material attractive, acceptable, and believable, then the material is fit to be used. So you just assess if 70% agree with you. But if it's rejected, you have a rejection, you have to find out why. Is it that the message, the weight portrayed is incomprehensible, is ugly, it doesn't take care of the sensitivity, or people find it inappropriate? You monitor the use and impact. This is so key. With this, you'll be able to find the findings to be able to improve distribution system, attract future designs of materials, and then identify and correct problems early enough to ensure changes and maximize impact. So what are so we move to the second part of the discussion, which is the use of IEC material. So the use depends on the target audience. So there are like 4 forms of IEC materials. It could be print, it could be visual, it could be audio, it could be audio visual. So for the printing materials, the production of multiple copies of an original image impressed onto a paper. So it involves the exchange of facts, ideas, and opinions through a written instrument or materials. It can be used as a medium on its own right or as support for other media. So you have examples of posters and flip charts, leaflets, booklets, cards, newspaper, magazines. So this is an example of a poster. So for a poster, the image is usually a large sheet of paper, ranging in size from large billboards to small notices, and it consists of words and pictures and symbols. So the words should be it should be in an understandable language, and usually it should have a maximum of 7 words. It should be few and simple. It should not be too much wording. So there should be more pictures, and the pictures should not be misunderstood. You should contain only one idea. You don't put multiple ideas on a poster, and it should encourage practice-oriented action. Okay, so like this one showing about the Buruli ulcer, telling people how to recognize Buruli action ulcers and how to act when they have it. Also, posters, it's better to use live pictures if possible. Using animated is usually not acceptable. Some people, it's preferable to be live pictures. Then the picture and message should be realistic. You should not put maybe somebody is flying on the moon, lying down in bed on the moon, or something that you know is not realistic should not appear on the poster. The color and everything um, should be eye-catching. Importantly, posters should contain the year of publication, the place, the area, and the sponsoring organization. And then the purpose or goal of IEC on the poster should be clear. So it should give information, advice, direction, or instructions. Also, for posters, is displayed in strategic public places and can be used to announce or advertise seminars or workshops on issues, and in fact invite viewers. If a reader is not conscious of a particular right, you can use a poster for them to live to make them conscious of that, to live a healthy life, quality of increase their life quality of education or protection, or what you want them to do. The IEC materials are usually used to interpret such hidden issues in terms of basic human rights so that actions can be taken. Posters can be used to draw lawmakers, government officials' attention to obligations towards the promotion and protection of the rights of their constituents. Remember that once a poster is made, it should be stored in a safe place. You should post them in a public place where a lot of people will have a wide view of it, like in a marketplace where there are a lot of people are there. Ask for permission before you put a poster on a house or a building. And then it's usually advised not to put it in a sacred or worshiping place. You don't want people to already have animosity towards you before your information is even taken in. And do not leave a poster up for a long time. So for flip charts, there are a series of, this is actually a series of posters on a related subject that are bound together, usually at the top, and can be turned over by the educator. It's usually commonly present several steps or aspects of a central topic. So you give information and instructions to the audience. Usually there should be in each sheet should have a separate idea on the chart so that it's not confusing to the audience. The arrangement should follow a logical order. And usually 5 is a good number for a posters to be put together in a flip chart. Leaflets, flyers, and handbill, usually short message printed on one side of a standard weight paper. So that is a leaflet, a flyer, or a handbill. Once there are more than 5 sheets, it is then called a booklet. And then when you have a brochure, is like a modified leaflet with message printed on both sides. Remember, for the leaflets is on one side, for brochure is on both sides. And it often explains the subject in details, useful for a long time. So the essence of a brochure, a leaflet, or a booklet is that the content should be clear, it should be accurate, it should be readable, and it also should be empathic. It should not be, you should, put yourself in the shoes of the people you are giving the message to. It should be readable for the audience. I came across this recently, and I saw that there's something called a photo novella. I was hoping I could share it with you guys, but I think that would be difficult. So there's this by the CDC where they have a brochure that has photos, like a comic, where they educate people on how to control their fat and cholesterol. It's really very interesting. The use of visual IEC material. So this includes things that are seen, words are not written, words are not included in visual IEC material. So there are like 3 main forms. You have real objects. So you can have the real object on the table or wherever you're having your program. So some people have had to display real intrauterine device, IUDs, or pills or condoms, so as if you are educating people on contraceptive um, measures, or you could make a model of that object. So usually a 3D object of real objects are used. You make a model when the real objects are not available, when it's too big or it's too small. Like you make models of a aeroplane, for instance, because aeroplane is too big for you to carry, to come and put on display. Or for mosquitoes are so tiny, so you can make a model of a mosquito to be able to show the people. So those are examples of visual IEC material. Then you have photographs. So you can just put a photograph. We've seen a lot of photographs, especially the ones that they usually related to Africans. You see a very malnourished baby or child, and that tells a lot. The war-torn area. And
Tu dois manger un bon petit déjeuner
at that enough should attract people to what you are
avant
able
ta
to understand
réunion
what you're
d'aujourd'hui.
trying to say. Then these visual IEC materials are usually used when illiteracy status is very low. So people will always get it. You don't need to talk too much. Well, just looking at it, you'll be able to get what you're trying to say. So my husband is an ENT surgeon. I know this model is on his table. So he uses it to educate people on how the ear. A lot of people don't even know the shape or what happens in the ear. So seeing this give them a better idea of what is in the ear. And then I assume the O&G specialist would use this to be able to educate women on how the baby is formed, the pelvic inflammatory disease or ectopic pregnancy, for instance. Using this to educate people enough to elicit action from them. So the use of audio IEC material, this usually anything that is heard, so such as spoken word, health talk, music, and sound. I know the young children of nowadays, you want to send a message to them, you just have to put it in music, because a lot of them are always listening to one music or the other. So that could be a way of reaching them. But we all know that the standard one is radio. Radio has a very wide reach. It's a very powerful tool. It reaches more people than any other media. Unfortunate thing with audio IEC materials is that they are easily forgotten. Maybe in the next few minutes or so or hours, they will probably forget what they've seen. But you could use radio, audio cassettes as to reinforce advice and information. So regular radio programming, for instance, can be used to promote a sustainable reduction and hopefully elimination of all sorts of things like child labor, child prostitution, and exploitation. Of course, right now, I think radio is the one that actually made a lot of impact concerning coronavirus, where even people in the villages know what coronavirus is all about, know about washing of the hands. I think the radio has done a lot in that. And because of the way it operates, it has this continuous reinforcement. We keep running the program repeatedly. It sort of stays longer in people's memory. So the audiovisual is the most preferred. People are seeing and listening at the same time, just as we're doing right now. So it includes the use of television, projected materials, films, videos, phones, laptops. So most times the message conveyed through this material is really highly motivational and it appeals to people. Sometimes it shows real life situation and messages are not easily forgotten in this media. So the use of IEC materials, for instance, now using the adolescent health program, some children, for instance, may have suffered through making wrong decisions. Audiovisual can contribute substantially in decision making by creating a mental picture in the mind of the viewer. So, for instance, you have a picture showing the adverse effect of child prostitution. A child prostitute being used for ritual may put fear into the child because no child really wants to go through ritual killing. And the use of such pictures along with words will add tremendously to clarify an idea and help children make good decisions. So when you're assessing IEC material, what are the things you look out for? The objective that you have set out to do, does it stand out? How attractive is this material? Does it appeal to the heart and the head? Does it have a distinctive look and personality? The message and the design, do they synchronize in design, color, text, narrative, arrangement of the items? The information, is it simple enough? Is it relevant? Is it specific? Then does it do anything to the people? Is there anything in the material that will make people take action? Anything that make people will think this is beneficial to them? So I want to acknowledge our able president, Dr. Sagi and Mr. Ima Odiaka for use of their slides on the development and use of IEC material, and also to acknowledge Dr. Ibrahim Kamirat for the use of his slideshow on health education materials, methods and material of 2015. Thank you for listening. I don't know.
Hello. Thank you, Dr. Ibekwe, for that wonderful lecture. We'll just take a little break and we'll have some adverts after that. So, Mr. Fakoya, please. Please tell Ijoma to invite.
Yeah. How much? White or color?
This break is long, though. I thought it was supposed to be like some 2 minutes break.
I think it's 3 minutes, ma.
3 minutes break, okay.
Well done, Dr. Ibekwe.
Let me call her. Hello, Dr. Ibekwe. Is she?
Hello.
Yes, ma. Can you give us the next lecture, ma?
Okay.
Thank you, ma.
And you have to enable me to share.
Tell the Jama to make her post.
Yes. Okay, good. You're sending a message. Hello? Please.
I'm having difficulty sharing. Can you enable me to share, please?
Yes, we're working on that now.
Let her do the second lecture. Good. Who is the host? She's still the host. Tell you because she's still the. I am not the host.
Ma, you are the host. Dr. Ibekwe, continue the lecture, ma.
Okay.
We're seeing you. Do you know that?
No. That's Dr. Omar and that's Dr. Uche. That's not.
Good afternoon once again. My next presentation is on strengthening home-based care. I must admit that I didn't know of this until I was told to present this topic. I hope I'll be able to do justice to it. So this presentation is going to follow this format. What is home-based care? What are the models of home-based care? Essential elements of home-based care services. So I'm going to give 3 examples, one in Nigeria and 2 in other African countries. We'll look at the benefits of and obstacles to home-based care and then how to strengthen home-based care. So according to the WHO, home-based care refers to any form of care given to a sick person in their homes. And this form of care includes physical, psychosocial, palliative, and spiritual in nature. So it's not just health per se. There are 2 bases on which home-based care rests. You have the family and you have the community. The aim of home-based care is to maximize patients' quality of life, maximize their health and function through appropriate quality care that is cost-effective and includes a care for a dignified death. In Africa, home-based cares are mainly initiated by non-governmental organizations and community-based organizations, faith-based organizations, and concerned individuals Unlike in developed countries where where it's a serious thing, usually here government only endorses the provider. Most times these providers have to really pursue the government to be able to, get them involved in home-based care. There are two models of home-based care. You have the home visiting program and the comprehensive home-based care. So basically for the home visiting, usually, sorry, and then there are two forms of home caregiving. So you can have the formal, that is initiated and implemented through a formal structure, and then the informal, where you have family members and friends that are not paid. The formal one, you have a structure in place. People are paid. People know that this is their work and this is how much they are going to get from it. While the informal one usually is what is practiced everywhere in the world, where a family member, we've seen a mother who has to resign from work to be able to look after a sick member or things like that, and then there's no money paid for such service. So the home visiting service model. So you have the volunteers who visit the patients in their home. They'll spend time talking and educating them and their family about basic care services, provide support. In fact, home-based care also involves cooking and cleaning for the patient. So those are also part of home-based care. For the comprehensive home-based care, this one you have the training of caregivers. There has to be training. They provide linkage to or referral to healthcare center. So it's not just a doctor referring a patient. So you have these community-based workers, or even someone in the home can write a referral letter to a doctor in the hospital. These are all part of the comprehensive home-based care services. We provide some social support, and also you can even educate the patients for income generation, to have they can organize income generating activities for the patients. So there are three categories according to Ngama. He defined it in 2005, where when he looked at all the practice of home-based care around, he was able to divide it into three categories. So you have the isolated, usually the informal one. There's no formal referral, there's no link with any hospital. All it does is just offer home services for treatment of minor ailments, counseling, or support, or for education. So the common providers, I'm sure we're all aware of, is that church groups, individuals, concerned individuals. For the specialized and private, which I know some people are trying to set up, this has linked to hospitals and specialist care. So services include counseling, they supervise adherence to medications, they control symptoms, they educate and they support. And it works because there is health insurance companies involved. So people are doing the work they are being paid for. So they know that when they go to work, they get paid. Then we have the collaborative and integrated models, where you have all people, so a lot of people involved, and NGOs, faith-based organizations, community-based organizations, and hospitals. Sometimes hospital can take up this challenge on home-based care. So the people that work there can go to visit the patients' homes and offer home-based care to them. So there's a collaboration with a huge number of partners, and it's integrated into some healthcare programs. Then there are volunteers involved in this model. So what are the essentials of home-based care according to WHO? So there are essentially seven of them. Their definition of care. What exactly do you want to give to a patient? What is the meaning of care? The education aspect has to be factored in. Supplies equipment, staffing, sustainable finance, and monitoring and evaluation. It's advised that you don't start with the aim of having these seven elements, but at least you should work at um, bit by bit and try to achieve this. Once these 7 elements are factored in into home-based care, it's actually more complete. Look at the provision of care. So what exactly is the plan? Is it that you want to give a basic physical care? So maybe a patient that is moribund, a cancer patient, sorry, a stroke patient that cannot walk, he has to he can't easily move around. You just want to house and make sure that he takes his medication properly, he's doing his therapy, doesn't need to come and see the doctor in the hospital every time. So that could be just the basic physical care you want to give to a patient. Could it be palliative? You know, we have a lot of patients, like the dementia patients that, you know, there's nothing much you can do for them in the hospital. All they need caring for them at home. So that could also be one. Or someone that is terminally ill, you need to end near, be able to give them a dignified death. That could be palliative care that you want to give. It could just be a psychosocial support for the patient and the caregivers themselves. You know that initially, and even now, when HIV came around, when family members have to look after HIV patients, there was a lot of psychosocial support needed for the caregivers. It's not easy to have someone that is incapacitated and you have to care for. It could be for counseling purposes. There are some programs where for someone that is about to die, you can counsel the patient on what you can do what I mean is that what they can do for the people they are leaving behind. So, like those that maybe the widow, for instance, that is sick and is going to leave behind a child, so you can have a plan on what benefit will come to the boy or the child. So then the affected people, the affected people that you want to care for, or those that you are looking after. So those are the things that encompasses the provision of care. For the continuum of care, you have to factor if you want to continue, if want to provide a service and you want this service to continue, what are the components you have to look at? You have to make sure that that service is accessible. So the person that is going to visit the patient, whether a nurse, a doctor, a community healthcare worker, how can they access such care to the patient? How can they get there? How does the patient or the community know about this kind of care to be able to have it accessible? The continuity of care. How long do you want what the palliative? Is it until the patient dies, or the time the patient can, just set the goal. Then the coordination is very important. So if you are doing, especially if you are doing multiplicity of care, like something that requires a lot of care, let's say a diabetes that now has a stroke and they want to manage at home. So we are looking at three specialties involved. You have to coordinate which is now have physiotherapists as well. So there needs to be a coordinator involved. You need to keep the records. That's one of the problems of home-based care. How are these records kept? We know that there's this doctor-patient confidentiality. It should not be lost, even though it's a home-based care. How do you keep the records confidential? So those are the things that have to be factored in. Then, how do you find the cases to be included in this your provision of care? How do you find them? So those are part of the part of continuing of care. Then education is so important. Right now in the United States, they are advocating for curriculum on home-based care because really they feel that the medical students should be taught on home-based care. The nurses should be taught on home-based care. People don't just with the curriculum we have right now, we're not equipped with what it takes to be able to go and visit a patient at home and offer care. It's not in the curriculum. So is a special curriculum on its own, which has to be factored into the education. Then the outreach, sometimes you need to go on outreach to be able to tell the community that, look, oh, we have this service in place and please try and assess it and even garner their support. You also need to do education to reduce stigma. Some people, they will advocate one illness to one witchcraft or the other, or they feel that they are going to be infected by just touching the patient. We all heard this about HIV. So reducing stigma, education sort of reduces the stigma of any illness for the patient or for the community. Then you need mass media, the information has to go around, and then you have to evaluate this education, make sure that it's actually what you want to be educated, that people are actually getting the right message. Then we have the supplies and equipment. First of all, there is especially the comprehensive home-based care services being practiced. You need a location where the home-based care team will be, where they will gather and plan and look at how they can work, when to visit who and when not to visit the other. So there should be a location where they can be situated. Then there should be health center supply. So you don't just do home-based care with just your stethoscope, or you just go there. What are the things that you are coming with? Because there are even home-based care kits. One of the reasons why home-based care was not very popular in the US before was, what do? You go and see a patient, the patient is and looking anemic, and you don't know to what degree this anemia is. So is it because of a PCV that you have to bundle the patient into a car and go? So that's that was so difficult then. But now we have a way of checking the PCV of the patient, which is like inside pocket kind of thing. So it's much easier. Then there's also the one of X-ray. You go and see a patient, listen to the chest of the patient. You are hearing bronchi. You're not sure if the patient has pneumonia. Do you have to put the patient in the vehicle and transport to the hospital, or can you just do an X-ray right there, which some services in the US actually have? So the doctor going to pay home visit can actually do an X-ray. Then how do you manage the patient? How do we monitor and keep records? So those are part of the supplies and equipment aspect of home-based care. Then the staffing, like I said before, it has to be coordinated. If not, you can't continue, it can't be sustainable. So there has to be a coordinator and then the supervisor that will ensure that whoever is supposed to visit this patient actually visits the patient and does what it's actually supposed to do. So that is important. Then how do you recruit patients? Do you want to have volunteers? How many volunteers do you want to have? How many are going to be the main staff? Because of course you have to look at money, the cost involved. How much do you have and how much are you ready to give? So those are the things that has to be factored in. Then sustainable finance. Finance is so important. So you have to have a budget. How much are you want to spend on the patient? That has to be discussed. Are you going to have community funding? Are you going to get technical support from others? How are you going to encourage volunteers? So a volunteer, yes, doesn't get salaries, but there's some things that you do for them that will encourage them. So some people, they will make t-shirts for them. Some they will give them transport money or just small money for them to be able to keep coming and going to see these patients. Um, how do you pull these resources? Do you, like now that we have a faith-based organization, we have community, how do you pull these resources? How do they, what is the percentage each will contribute for what? Then how do you pay, does the patient have to pay from out of pocket or he has a health insurance? What services will be free? What services will you give for free for the patient? So those are the things that has to be planned and factored in. Then the last element is the monitoring and evaluation. You have to do quality assurance. Are you giving quality care? Remember, home-based care is useless if it doesn't give the quality of care that it's supposed to give. It's not just something that should be taken by not it should be taken seriously, really. It shouldn't be, the patient should be able to have even much better care than they would have had in a hospital. So let's have that in mind. Then the quality of care. What are the indicators that you are looking at to ensure that this patient is having the quality of care? How is the monitoring and supervision going? We need informal evaluation apart from the formal evaluation. We ask people around, how have people perceived this our services? How is it? What do you think we can do to improve? And then the flexibility involved. So like now, the most common home-based cares that we have is the HIV/AIDS patient and the TB patient. These are the patients that need to be on their drugs on a constant basis. So we need to be visited and ensure that they are taking their drugs. So these are the ones that are very rampant in Africa. Then we have the frail, home-limited elderly. So an elderly patient with multiple chronic condition and functional impairment. These are patients that benefit from home-based care. And we also have young people who have neuromuscular diseases that cannot move around, so they also can benefit from home-based care. Then we have um, maternal and neonatal death reduction. We could do that as a home-based care. Then palliative and end-of-life care. And of course, right now we know of the COVID-19 patients that are receiving home-based care, which is also something that is being practiced as we speak. So looking at the examples for Tanzania, we have this government set up a multi-sectorial form of home-based care. And the operation of care, the continuum of care, was for people living with HIV/AIDS and other chronic diseases. So their mission was to ensure a continuum of care for the people living with HIV/AIDS and other chronic diseases living in their homes and their families. So they had members from local health centers, non-governmental organizations, faith-based organizations, community groups, and traditional healers. They were organized into a district management team that was headed by a medical officer. So each one was organized by the government. So they made sure that this mission was achieved. Other elements there also include assessing and listing community resources, um, providing education for effective coordination and referral, and providing solution to gap in services. Quite a huge one, and it's working for them. The second case is in South Africa. This is Moretella Sunrise Hospice. It was started by a nurse who saw the need, where she realized that people that are sent home on palliative care, that are on terminal illness, they are not being well looked after. So she resigned her work and started this up. And people were watching her and realized that she was really serious about this thing. And the community rallied around her, and right now they have a well-established hospice. So their own include provision of care for people living with HIV/AIDS and other chronic and terminal illnesses. So they provide prevention, education, counseling, and support. They refer ill patients for treatment, and then during terminal stages, the ill patients and family are supported through the hospice program. In fact, they even include helping them to write their will and planning how the life of those that they left behind is going to be. So it's really a very rich program. So they educate ill people and their families on basic nursing care, universal precautions, nutrition, and they're even having the income generating activity, and how to, like, their own was how to grow natural herbs and medicine, which is part of the program. Then this is the nurse and some of the groups. So this actually, they contain of a palliative nurse, a social worker, a pastor, and a psychologist. They had four program supervisors, four trainers, and 40 trained volunteer health workers. This is a case in Nigeria, Delta State Ministry of Health and West African Health Organization in Oshibili South local government. So their provision of care was for pregnant women, and their aim was to decrease maternal and neonatal mortality through home-based care. So what exactly were their elements? So they had community health workers to identify women of childbearing and reproductive age in the community. They made a list of women who were pregnant. They visit every pregnant woman and register her on a pregnant woman register. And they use basic communication skills with mothers and families to educate them on safe antenatal care, delivery, and postnatal care. So on the first visit, they encourage all pregnant women to go to the nearest health facility to ensure antenatal care, blood pressure measurement, iron and folate supplementation, tetanus toxoid injection, intermittent prevention and treatment of malaria and HIV screening, and monitoring of fetal growth and well-being of mothers. Then they conduct a health screening for possible dangers of pregnancy, and they refer these patients once they observe ones. They also distributed insecticide treated bed nets where appropriate, and they provided health education on the importance of antenatal care and danger signs and appropriate actions in pregnancy. Um, During the second visit on the 8th to 9th month of pregnancy, so they conduct health screening as earlier mentioned. So if they didn't see the woman in the first visit, this visit they will undergo what they did before. They completed a birth plan with the patient. So the participant, they asked, where do you want to deliver? Do you want to deliver at home, or you have a facility you are planning to deliver? They encouraged HIV positive women to deliver in a health facility that offers pregnancy postnatal care. They encourage the use of maternity waiting homes, or stay and encourage them to stay with a relation or friend to be closer to a health facility, as if they live very far away from a health facility. They provided education on safe delivery. They did that all over again. Of dangers during delivery, immediate new birth care, breastfeeding, care for mother and after delivery. And then the community health worker goes with a kit, so which included a thermometer, fecal manometer, and pulse oximeter. Um, During the delivery and postnatal care, they encourage relationship between the delivery between the patient, or I don't know whether to call them patient, but the person and the wherever she wants to deliver, whether with the community health extension workers or family members or birth attendants, if it's at the health facility, or they themselves attend to that delivery. They are there with the woman delivering. They record all information on the delivery form. They give emotional support to mother and family. The postnatal care will now they now had a postnatal care visit where they visited the mother regardless of where they delivered, and they conducted 3 home visits for mothers and 5 for the newborn on the day 1, day 3, 7, 15, and 28. And they were given a checklist on what to do at each visit, and the data was collected and used to monitor and evaluate the program. Um, Looking generally at home-based care, if you look at the benefit is quite a lot. You have not the idea of nursing a patient in a familiar environment. So most people like to be in their home. There's nobody likes hospital environment, especially when the situation is quite severe or near death experience. So being in their home is so important to a lot of people. Um, Healthcare is made affordable to all. So there are some patients that you can't afford to be on the hospital bed and paying all the bills. It's much cheaper for them if someone comes to visit them at home. So it provides healthcare, makes it affordable for all. Um, there's a good support for family. So the family care members, the caregivers, they sort of feel encouraged when people come and support them, caring for someone that is very ill. It decongest healthcare facilities. I can't say how many times that we've had patients on the ward that it should be at home. There's nothing much you're doing. Every time you call, continue present management, continue present management. But because they don't have any way of having a home-based care, which people, and the bed where they are in, people are supposed to be there. There are other ill people that are supposed to be there. You can't send the patient home because they don't know who will continue the care from home. So it helps a lot in decongesting healthcare services. It dignifies end of life events. So like I said, a lot of people prefer to die at home. They don't like dying in the hospital. Um, the obstacles are also there. So sometimes the patient doesn't even dare you to come to their houses, because coming to their house is like reminding them of how sick they are. It's so depressing. They want depression part to be in the hospital. Then at home they are free from the doctors and the nurses and the forcing up and down. So there are some patients that will prefer to go to the hospital for hospital things and then be at home for their own concern. Then the physician's concern, yeah, there is a fee aspect, which is something that is being talked about all the time. So how do you pay the physician? Do you pay per visit or do you pay at the end of the month for value given? So those are issues that are raising concerns. And then, like I said, most physicians don't have adequate training to offer home-based care. So those are obstacles. Then lacking of supporting infrastructure. It's not. I've not seen a portable X-ray machine. So those are the issues. You want to visit a patient at home, you need to do some tests for the patient. How does it help you to be able to give this quality of care? Then people that are coming to the hospital don't even have health insurance, talk less of those that are at home. So that's a big problem. And we know that without a good health insurance, we can't be able to offer a appropriate care for a patient. Then there's this problem of confidentiality breach. You know that in home-based care, there is a lot of volunteering. In fact, most times when you look at the structure, the doctor, the physician is a volunteer. You know, but the nurses can get one or two paid, the physiotherapists here and there, but most times it's a volunteer thing. But that aside, you have people that are non-medical that you recruit as volunteers. How did you ensure that there's no breach in the confidentiality of this patient? Especially when it comes to HIV, you say, oh, look, that person, Mr. So and so have HIV. This person is, this is how it is, this is how it is. Those are the obstacles to it, and it is not good to have that breach when it comes to healthcare. Then there's poor or lack of proper regulation. This is also true. Even in the US, where home-based care is being practiced, we hear a lot of scandals. People don't really do what they are meant to do. They come as they probably just from the computer refill the patient's prescription and that's it. So those are obstacles that can arise with home-based care. So how do we strengthen? These are my own personal and I hope um, opinions. Number one, we need to have a formidable policy. People, the federal, the state, the local government, district level should have it as a policy that they want to implement home-based care. And with the government, you have a structure. It's institutionalized. You have where to place who to do this and who to do that. So if you don't have government backing, most times it fails. It doesn't work. You can't have continuum of care. Then the provision of funds and financial backing. You cannot afford to give health without money. It goes together. So already the hospitals are crying they are not well funded. I'm not sure about home-based care, how they can look at it. But it's also something of importance that people should look at and provide financial backing for. Sometimes it can even be that the caregiver, because like I said, a wife has to leave her work to be able to care maybe for a husband or a child, and there's no compensation for that. I think that would discourage, that would, if there was a financial backing for such, it would encourage home-based care for especially terminally ill or very ill mobile patients. Then we need to increase awareness and education of healthcare workers. And thank you, Madam President, for educating me. And I hope I'll be able to educate my fellow women on how important this is, because it's really something we should look at. Then we need to also increase awareness and education in the community. Um, if you don't have the backing of the community, nothing works. You can just frustrate the effort. Then we need regular evaluation of the program. So you set up a program, you regularly evaluate it to ensure that it's actually working um, and achieving the aim is set out to do. So this is like a planning. We want to plan a planning or policy framework for home-based care. So want to know what is the nature of the program, what is the purpose, the goal, objective. Remember, you can't care for everybody at the same time. You just pick one or two target population, pick a locality, just like the Delta State um, did. Then the eligibility criteria, which age group are you looking at? Which disease category are you looking at? the degree of disability, the relationship of caregivers, are they going to be paid or not? Are they going to be helped or not? How many hours will be offered for each visit? What is the ability to pay? Is it the patient that is paying or the government that is paying? Then the general state of the home. Is this going to involve cleaning the house, cooking for the patient? You need to have a criteria. Then eligibility to, who are those eligible to be in this program? Like the community health extension workers, they went to the community and they found out the pregnant women there. Those are the people they recruited into the program. So what will be used to assess this tool? Who will be the assessor? What is the measurement of care that you want to give? So the benefits. So the patient you want to give this, the person you want to offer this provision to, is it going to be a service provision or a cash provision, or both? What is the maximum and the minimum benefit an individual can get for each program? Are you going to give medicines? Are you going to give supplies? Even transportation. Like now, sometimes you need to refer the patient to the hospital. For transportation going to be part of this program. The counseling is also there. Are you going to assist with housework? Then the program operation, is it going to be government run or joint with other organizations? Who is responsible for the services, for education, for quality assurance? Then also for financing, is it going to be through general taxation, cost sharing? Is it going to be distributions from non-governmental organizations, faith-based organizations? Those are key. Then for the cost of the service itself, what is the ratio of paid to unpaid workers? Because there has to be paid workers, those that are retained staff, like the coordinator or the supervisor, for instance, have to be paid. But the volunteers don't have pay. You don't pay volunteers. So what is the ratio going to be like? You have to educate those involved. It's going to cost. So you have to put in cost for education, put in cost for medicine and supplies, and even transportation. So I would like to conclude by saying that home-based care is defined as any form of care given to an ill person at home. And there are two service models of home-based care. We have a home visiting, say you are doing home visiting, or you are doing a comprehensive um, um, home home care. Then there are two forms. We have the informal and the formal. I've enumerated 7 essential elements of home-based care services, and I've provided examples of home-based care programs in Nigeria and 2 African countries. The benefits and obstacles of home-based care was highlighted, and points on how to strengthen home-based care was discussed. Thank you very much for listening.
Okay. I want to. Hello, thank you, Dr. Ibekwe, for that great lectures. We're grateful. So we'll have our advert now, and after that, Dr. Umemu will take on her lectures. Thank you.
Can I hear you? I'm a
I don't have to. Please, we're really sorry. We're having some technical issues. So we'll just continue with the next lecture where we'll see if we can rectify it. So Dr. Memu can be made the co-host, so that she can share her slides. Thanks for understanding.
There are 50 people waiting outside.
Okay. Please, you've not disabled me.
She's ready.
I'm there. Can you hear me?
Yes, we're hearing
Loud
you.
and clear.
And we're seeing you.
Okay. Can you see the slide?
Yes, we can see your screen.
Okay. Okay. Is my camera on?
Okay, that's it.
Yes. Good afternoon, everybody. Hello.
We can hear you. Go
Can
ahead.
you hear me? Can I go ahead?
Yes, please.
Yes,
Okay.
good afternoon, ma'am.
Good afternoon, Able President, the NEC members, all our visitors here in Abuja, and my lovely colleagues. I'm Dr. Maureen Umemo. This afternoon, we're going to look at health education and social mobilization. I don't want to introduce myself further because I know that we've been interacting and my colleagues are aware that I'm consultant obstetrician gynecologist with National Hospital, Abuja. I'm also the secretary, M1 FCT. I'm recently the vice chairman, NMA FCT. You're welcome, the people that are physically present to Abuja and everybody that is connected. So we're going to look at health education and social mobilization. And we're going to follow the following outline, looking at the objectives, looking at the method, the principle, and also looking into social mobilization, because when we're talking of health education, we'll definitely talk of the social mobilization and approaches to go about it. So as a way of introduction, health education is a fundamental component of primary health care, as contained in the Alta Declaration of 1978, which also clearly underscores the importance in this statement. You know, because before 1978, we look more to the causes of diseases, how to prevent it. We're not actually looking into the basic causes of it, the community involvement. So by this 1978, a declaration was made that the people have the right to know the prevailing health problem concerning them. And the method are supposed to use in preventing and controlling them. And also people are supposed to be involved in their own health promotion. We all know that health education is an essential component of any program that aims to improve the health of any community. And among other things, there must be community participation. The major thing we are talking about in health education, and that's the main thing I feel is important for us as medical women, even though we are doctors, to discuss it. For us to know that health education now is not only to stand and talk. We have to involve the community. We have to allow them to also air their own views so that health education as is now handled is a communal participation both for the healthcare giver and the community. Healthcare is more than theoretical knowledge. Sorry, I'm having some issues with this. But an art which must be learnt over and over again. It's not something we feel because we are doctors. Why are we talking about health education? No, it is something that even though we are doctors, we need to also be conversant with health education, because we can be doctors and know all the things about diseases. But the modern lifestyle is the major thing exposing us to lots of risks. And that is why health education is very important. Good health lies in our hands. It is the way we handle it. Are we working together to get that health? And in spirit of self-reliance and determination, we will be able to sustain it. So with the brief instruction, I would also now like to define what is health education as done in 1978 declaration. Health education is defined as a process that aims at encouraging people to be healthy, to know how to stay healthy, to do what they can individually and collectively to maintain health and seek help when needed. Health education with the new definition is no more one-sided kind of work. It's no more doctors to patient. It is like a collateral kind of definition. You tell them about health, what they need to do individually to get that help, how to seek help when they need it, and most importantly, they must be involved in health education. Now, why are we discussing health education?
What's up for?
What?
If the children achieve the score of 5, they are considered to have minimum dietary diversity.
One.
Hello? Hello? Can I go ahead?
Yes, ma'am.
Hello? Can you hear me?
Yes, ma'am.
Okay. Aim and objective of health education is to encourage people to adopt and sustain health promotional lifestyle and practices. The first thing that we've read, we are doctors, but we need to educate people around us. And we can only do that through health education. If we have only the clinic work, and we're not talking of other environmental factors for health education, we won't be able to deliver health education to the people that need them. So for us to promote the lifestyle, we need to involve health education. We also need to promote proper use of health facilities. Proper use of health facilities, I mean here, is not to just cite health facilities. There are our people using them. That's another thing why we are talking about the health education. Our antenatal women, are they using the facilities meant for them? If we don't talk to them, they won't be able to know. Then to arouse interest and provide new knowledge, improve skill, and change attitude in making rational decisions to solve their own problems. We have to create that interest. If we want to improve, let's say, the health of women around us, we have to create the interest. We have to talk to them. We have to tell them the new things we have in health. If we don't do it, if we don't even improve the health of the primary health care and community, it means that there is an issue with the health education we are giving. So, when we look at this aim and objective, you will see that we'll be able to stimulate individual and community self-reliance and participation to achieve health development through individual and community involvement at every step, from identifying problems to solving them. If we don't educate people and we don't follow these processes I've just mentioned, we might have a lot of things in our hospitals. Meanwhile, the communities are not involved. The communities are not well educated. They are not well utilized. So because of that, there is need to educate our women. There is need to educate our women using health education and everybody. So how are we going to approach this health education? Approaches have varied in different ways to know how to move in health education to the people that are supposed to get it. And you can use the regulatory approach. We can use the service approach. We can use the health education approach, and we can use the primary healthcare approach. I will just, in a summary, few summaries about the different approaches we are supposed to use. The first one is the regulatory approach. This is when government designs something like a law that we will use in handling our health. But the problem with the government aspect is this: if you put a law, you cannot force people to abide by the law. You can put a law and put a punitive measures, but that having solved the problem, because it is like a unilateral kind of measure. People are not compelled to obey the law. In this situation, there is no community involvement. There is nothing to entice them. They are not educated. We are not giving them the knowledge. They don't even know why they are doing it. So when you look at this aspect, you know that it is completely defective. Then we consider the second one, which is the service approach. In this one, government usually provide the basic needs of people to their houses, to their communities, to their environs. But the main thing is this: if you offer and you don't educate them why they should do it, they will not do it. Take for instance, you can go door by door to immunize the community, but if you don't educate them through their heads, through the people that are familiar with, they will not comply. So using the service approach is also not the best. We now move to the health education we're also talking about. We need to educate people. It's a planned learning experiences. What to do and to be informed, educated and encouraged to make their own choice for healthy life. We have to use health education to educate people. But this is slightly defective because it's lacking community involvement. Because no matter what you say or you talk to people that are not familiar with you, they don't know where you are coming from, they might not listen to us. So even though health education is very important, but the community involvement is the paramount, because we need to get them involved. And finally, is the primary healthcare approach. This is the new approach started from the people with full participation and active involvement. In this situation, there must be active involvement of people we are dealing with. There must be community involvement. There must be intersectoral coordination. So we don't just bring in health education without involving the people in the community. It will be so clear that they will definitely take it with a pinch of salt. So the mainstay is the primary health care approach, so that there will be community involvement in everything we are doing while handling this aspect of health education. We are all healthcare providers. Is either we're working in the primary healthcare, secondary, or tertiary healthcare. What is our work, or what are we expected to do? We need to provide opportunity for people to learn how to identify and analyze their health-related problems and how to set their own targets and priorities. As a health provider, you don't set targets for people. You educate them so that they'll be able to set targets for themselves. Our role is to guide them. Our role is to educate them and not to impose it on them. So as healthcare provider, we just need to educate them. We have to also make health to be accessible to them. Because if we go to any community and talk, we're giving health education, and there is no health facility or health things we put on ground, it means that whatever we're doing is in futility. So there must be information on how to access health facilities around, and also indicate to the alternative solution to solving identify health problems. If we go to a community to give a health talk, and during that process, we're able to define that this is the problem of this community. A healthcare provider is not supposed to stop at that. You must create a solution. How do we help this community? Because take for instance, if you go up north, the problem there is VVF. You go down south or Yoruba is another problem. Maybe female education, the problem is that they're not educating their females like in Southeast before. So you see that the problem you are going to solve up north is different from the one you're going to solve down south. So we need to go to the community and identify the problem we're going to solve as a healthcare provider. And we now have to solve it. Now, when we're able to identify the proven measures, proven preventive measures, now we now put it back to the community. Because in healthcare, we are talking about health education. It's a combined effort, both from the healthcare provider, from the community, the leaders. Unless we move our healthcare education in that direction, we'll continue with our normal talk, and we are not getting anything out of it. Now, as we move to the community to give our health education, how do we go about it? We have the visual aids we are all familiar with, the posters, the charts, and all that, the radio, tape recorder. It's just any way you can communicate, things we can use to communicate to them. But the most important thing is this: know what is available there. In a place they don't have light, you can't be communicating to them through television. You must know what is available there, so you'll be able to discuss with them, and also to discuss with them in the language they can understand. Because as a doctor, you go to a village and you are using medical terms, they can't understand you. So we have to consider the available things, the aids we can use to pass our health education. Now, what are the ways we can use in passing this health education? We can use individual approach, we can use group, you can use mass approach. So we look at them individually. In individual approach, that's one-on-one discussion. But one thing is very important. In one-on-one discussion, even in our clinics, we used to talk and talk. But now it's been advocated that one-on-one discussion is a free way that you talk, you allow your patient to talk, you listen to her, you know her opinions, you can only try in a way for her to understand and not canceling out her opinion, because they're still holding to the opinion. So it's like a bilateral kind of talk. It can also be home visits. We can decide to visit a community where there is prevalence of a particular problem, and we try to solve that particular problem by visiting them, like in pediatrics, especially in pediatric care, how to feed their children, how to take care of their environment. In outbreak, we can do house-to-house visit during this period. For the ones that can read, letters can be written to them. You don't take letters to people that cannot read. So each one is peculiar. You have to define the people you are talking to before you move to the particular one you are going to do. We can also do group approach. We can give lectures. In that kind of setting, we are always advised, especially in community, to keep it group of 30s. You don't keep a large crowd of people that you cannot control and start giving lectures in communities. Then demonstrations. You can demonstrate what you are teaching them. And it's advisable that when we are using demonstrations that is in group of 6 to 12, you don't gather 30 group of people and start demonstrating. Basically, some will follow and some will definitely not follow. Then the panel discussions, bringing experts together. We can bring experts from different areas to discuss the prevailing problem that is going on at that time. Conferences that were used, workshop and other things. We can also use mass media like radio, as I said, television, internet, but you know that in health education, we can't be talking of internet in a village without light. So we have to choose the one that will fit them at that time. Now we have to look at principle of health education. Because as I said, you know, when we mention health education, like initially when I got this topic, I said health education, we are all doctors. We know everything now. We know how to give education. We know how to talk about health education. But you have the principle you can use to do it and do it well. First one is credibility. It must be credible. You must be trustworthy. They have to look at you first and develop that trust in you and the message you are carrying before they will be able to carry it or listen to you. So while giving any message, you have to consider that the messenger and the message is credible. And the message you are going to deliver will be able to ignite interest. Their interest must come up. And the community will participate. And it's not to gather people and talk to them about health education. It should be an interactive forum. They will be able to talk to you what they have in mind, their culture, what they are thinking. So it's an interactive. It's not just to mount and say, do it like this, do it like this must be done like this. And apart from that, motivation. It must be a message that can motivate people.
But as we are talking Nigeria today, we have been training nurses for the Western world to employ. And this is creating.
Can I go ahead?
Yes, we have just about 6 months.
Hello? Can you hear me?
Yes, ma'am.
Hello?
We can hear you. Ignore the
people. We can hear you, ma'am.
We can hear you.
Okay. So another important thing is comprehension. We must deliver a message that people can understand. You can't go to a community and use medical terms. So they will be able to understand us. You can't go to a community where they don't speak English and use English for them. You must get an interpreter. Then learning by doing. Reinforcement is when we deliver the medical education, we'll be able to talk on it. Repeatedly, so it will be reinforced in whatever they are doing. We also learn by doing. When we are teaching something, we make sure that what we are teaching is what we are doing, so that people will emulate what we are doing in what we are teaching. And we must move from known to unknown. We have to start with what is known. You are going to a community. We must know what is their own belief in that community. what have they been doing? So you'll be able to move from what they've been doing to the new things that you are about to teach them. We also set an example. Have a good human relationship. This is very important because when we are talking of health education, we need people around. We need people in the community. We must establish a relationship that we will use in handling health education. And whenever, after delivering a health education, there is need for a feedback. Feedback tells you how they looked into what you told them, their preparedness to embark on it, their eagerness to, I think we have so many background noise. Then, while talking of health education, we must talk of our leaders. You are going to a community. You must find out who is the head of this village, who is the community person there, who is in charge of this particular thing. If we don't do it, you can't jump as a foreigner into any setting or any village and deliver lecture or any kind of education, and you want them to believe you. So because of this, for us to give a good health education, we must know how to mobilize. Social mobilization is very important. It is through the social mobilization we'll be able to get the leaders, we'll be able to get the market women, we were able to get the village heads to carry out what we are talking about in health education. And that moves on to the next topic of our discussion. We cannot talk of health education without social mobilization. So we move to, why is so much background noise? Hello? Hello? Hello?
We can hear you, ma. We can hear you.
Okay.
Hear you, ma.
So for us to be able to deliver a good health education, we must talk of social mobilization. What is social mobilization? Social mobilization as a term is actually a military terminology. Prepare forces for action. We've spoken about health education, how we go about health education, but we need to prepare for the action. And how do we prepare for the action? Is through social mobilization. So social mobilization is a process of motivating communities to organize in a cohesive group for an active participation towards their own development. When we talk of health education, we talk of community development, we need to mobilize them. If you look at the diagram here or the picture, you see different hands. We must come together. Almost said, this hand is like M1 hands. But I saw another hand, I think is a man. So everybody must come together for us to mobilize. And that's all what social mobilization is all about. It is a comprehensive planning approach that emphasizes political coalition building and community action. If we don't come together, if we don't mobilize, all our talk will be in vain. So it is a very important key in health education. In every other areas, politically, anywhere, we need that social mobilization for us to achieve what we want. And how do we go about it? The process is concerned with mobilizing human and financial resources through 5 main approaches: political mobilization, community mobilization, government mobilization, corporate mobilization, and beneficiary mobilization. We move to political. You know, as doctors, we are basically apolitical. But for us to move, even as M1, we must move towards political aspect. We use political mobilization to make our point. It is not only staying in the hospital. It is not only prescription. It is the time we can get up and move politically. Political mobilization. I'm going to use what happened in NMA-FCT as an example. During the last M1 election, not M1, NMA election, M1 came out fully, and I have to thank at this juncture our president that awakened our other presidents. But specifically, you will bear with me that this last concluded NMA election, we did so well. We came out, we moved and mobilized people. Like NMA FCT, M1 FCT came out fully. In fact, other contestants, the male counterparts, were trying to get into M1 for support, because we came out politically and mobilized our members that this NMA FCT, we must have a female representative, we must come out and vote. This is all about social mobilization. And when we do it, we will say that we are not only M1 again, but we are also a political group trying to make a statement. M1 National can also mobilize. We can say for M1, election is coming, we have to put our ears out. Any woman coming out, provided it's credible, we will support. Because the health is no more only clinic affair. Politically, we have to be there to make a change we are looking for. So we can also mobilize among ourselves. See market women that are great force, despite being illiterate. The way you are talking of politics now, the market women must be remembered. Because they formed themselves together, they've mobilized politically and decided for we in this market, we will be able to make a point. M1 can also do similar thing, exactly what we are already doing now, but we can do more. When I attended NEC meeting, we were told that even though women were given 35 or 30% lot for us to cover, we only covered 6%. Because politically we are not mobilizing. So political mobilization aimed at winning political or policy commitment for a major goal and necessary resources allocation to realize that goal. The primary method of political mobilization is lobbying. I hope we know that there is a difference between lobbying and bribery. We want to make a way for political mobilization, we must lobby. We must lobby key people. We want these posts, not only in NMA, but in our local government, in our state. That we are female medical doctor doesn't mean we can't be commissioners, we can't be ministers, but we have to mobilize. When we know that, when they know that M1 is existing, when it comes to politics, when we talk, they will listen. And it's only through that mobilization we'll be able to do a lot in our health sector. Nigeria is turning to home of maternal mortality. It's directly under us. We have to do something, and we cannot do it by just staying. We have to lobby, we have to go to National Assembly, we have to see the key people, we have to also vote our women into National Assembly and Senate, so that when they mention such a thing, they will rise up and talk to us. Political mobilization is very important. Then we move to community mobilization. It's aimed at informing and gaining the commitment of community leaders, as well as local government agencies, non-governmental organizations, women's groups, and cooperatives. Community in terms of health. If we sit and we don't move to communities, we will not be able to give them the health education. I think that M1, we've been doing much in that respect, but we have to do more. We have to take our health to the primary center. This morning we paid the courtesy visit to primary health center in Abuja, and they were talking what are meant to be done, that is, if we don't go to the community, if we don't push them to the community, if we don't engage them, You are in charge of primary health care. Our women are dying in that places. We need you to be there. We mobilize with the community to ask for what is rightful for us. We can't do it by just sitting down. We need to mobilize the community. How do we mobilize them? We must know the community we are dealing with very well. As I mentioned before, you can't be telling community that VVF is their major headache about sending to education. You can't send the community that their mothers are dying about another thing. So even as M1, we can identify a community, study their problem, use it as a pilot study, and move on from there. But we must know their needs. And apart from that, we must know their beliefs. If it's the group that said, no, family planning is not good, this and that, we can't jump in there and tell them it is not good. They will report us. They can't accept it. We have to mobilize their heads. We have to look at the people that are key stakeholders in that community. We have to talk to them. When we talk to them carefully, they will be able to listen to us. You always make them to listen. Then we should not be very fast in introducing new measures. There's no need that it's done like this. We want it to be done like this. No. It's a gradual step. When we gradually move into a community, we'll buy their confidence. They trust in us, and they will be able to listen. Also, we also have to analyze the community dynamics. In the community, maybe it's their head is the stronghold. Maybe it's another person. Who is the people talking? In any community, they listen to somebody. So we need to find out. We have to involve the community from the beginning of the program. It's not halfway you say come in. You involve them from the beginning. What do you want us to do? How do you want us to help you? It's only when you give that and you are very cautious with any negative feelings or any negative thing happening in that community, they will be able to listen to you. So it is a systematic approach if we want to get community mobilization. But everything we are doing, if it's not felt in the community, we've not started. We can be doing roundtable and talking. The community are not involved. We need to bring them on board. We need to know their problems. We need to know how they want us to solve their problems, and we now know how to direct them. Government mobilization. You know, when we mention social mobilization, it's not only community. We stay in government, we are here, government, they stay together, they fund their laws, they plan what they want to do. What is our own role? If we don't meet them to tell them, this is how we want this thing to be done. We were told this morning, primary healthcare, where we went to, that would have meant to do this, do that. In fact, for primary healthcare, is 40% in the hospital and 60% in the community. If we are aware of that, we'll be able to mobilize people in government. We have social allocation for the primary health care. So we can also use it. Oh dear. We can also use this. Sorry, my. Hello? I'm giving lecture. I saw her in the hospital. Because I come and. Sorry, I'm on call. Let me just call her FC. Just give me a few time. Let me call her. Okay, I'll call her. Hello? Hello? Can you hear me? Who is it? Hello? Can you hear me?
Mute your mic. Mute your mic.
Can hear you. Can hear you.
Please let me locate my my president. I need to move to locate the people on course visit are having issue.
G, please mute your mic.
Where is the note? So sorry, I was discussing with the people on courtesy visit. Yes, sir. Where's my picture? Where's my picture? So we're on political mobilization. I hope I can go ahead. Hello?
Please go ahead, ma.
Yes,
Okay.
please go ahead.
Yes. So as an association, we have to mobilize also the government agencies. Because I was saying that today in primary health care that went this morning, they were telling us, primary health care, this and that. So it's just that we are not involving them. And also their location, all these primary health care centers are supposed to be taken good care of. They also told us what they've done and all that, but we need to supervise. And we cannot do it if we are not mobilizing the government people and politically. So it is no more only health, it's getting involved. What are the government people doing? Politically, we need to put our own people in a strategic position so we'll be able to mobilize. So government mobilization is also very important. Then corporate bodies, you know, we don't know that all these big organizations like MTN, Glo, are entitled to some corporate work. M1 can organize a big something. Why involving this big organization? Because corporate mobilization aims at securing the support of national and international companies in promoting appropriate goals, either through the contribution of resources or the carrying of appropriate message as part of the advertising or product labeling. As M1, we have all these big organizations with us. We can mobilize them to sponsor us. We can mobilize them to move into action. We have to be aware that we have them because they are responsible for corporate duties to us. One company once invited me that they are thinking of what to do, their corporate work, they are thinking of resource negative. So you find out that some of them, they even have the money, they are just looking for who to partner with to be able to deliver it. Because I think from my discussion I had with them, MTN precisely when they invited me, I now noticed that every year they map out an amount of money for corporate responsibility. So it's for us to key into such an opportunity. And then we have the beneficiary mobilization for people to benefit. You can tell women, okay, I have 100,000 loan, but you under 5 must be fully immunized. Bring the card for them, then we mobilize you. You have to do something, then we set up work for you. That's the beneficiary mobilization. So even though we're not that buoyant, but anyone can say, if you do this, you go and check for your cervical, your personal screening, then when you will come for it, we do so for you. You want to mobilize them using a beneficial target. And with that, they will join. So this summary of what I've just said. So finally, what's the key element in social mobilization? It's about partnership building and networking. You want to mobilize, we have to network. We have to talk to people. We have to get key people. We need people to support us. We can't stay under this one after social mobilization. We think we can go ahead. No, we need government. We need people around. Then community participation also. Media and special events as mentioned, and also advocacy. In partnership, we need synergy, I've just said. We need organization groups, members, different people, stakeholders that we can work together with. Also, in community participation, I've spoken to an extent, getting the community to be involved, using our mass media, radio, television for them to be involved. Then advocacy, we need to talk to people. It's an act or process of supporting a cause or a proposal. So we have to write a proposal of what we want, be able to talk one-on-one with group and for others. Then we have different levels of advocacy. In advocacy, I can speak up for myself, or I can speak up on behalf of another person, or we can speak on behalf of those who cannot speak for themselves. My lovely M1 sisters, who are those people that cannot speak for themselves that we need to speak for? Is it the high rate of maternal mortality in this country? Is it the high rate of cancer of the cervix in this country? Is it the institutional rape that is the order of the day now? There are people that cannot speak for themselves. We need to speak for them. As this man spoke for these lovely children, that's the one way people are looking up to us, the medical women, the best, to look at what is happening in our health sector, in our political arena, in our government, and speak for the people that cannot speak for them. We can agree together today to speak on our maternal mortality. We can agree to speak on our cervical cancer issue. We can agree on the rape or every other thing, the people that cannot speak for themselves. This is the time to mobilize and speak for them. Thank you.
Thank you very much, Dr. Mwemu, for the lecture. Very grateful. What an excellent presentation we have today. So time for Dr. Echo to give us her lecture on social services. We'll take questions, comments at the end of the lecture. Let's get our questions ready. Thank you. So Dr. Echo, is your turn.
Dr. Mayman needs to stop sharing.
Mama, is daddy.
Which daddy?
Good afternoon, everyone. Hello, Dr. Ali, can you hear me? Hello? Hello?
I hear you.
All right. So good afternoon, Madam President, my elders, and colleagues. It's been a long day. I'm very grateful for those who have stayed from the beginning till the end. I thank M1, the National President, for giving me this opportunity. I'm going to be speaking on school health program, an aspect of social mobilization for health. So I am Dr. NEC from M1 FCT. At the end of this presentation, I hope that you would have understood the relationship between social mobilization and school health program, know the concepts of the school health program, identify the challenges to implementing school health program, and then make recommendations. I'm following this outline. So many things on this screen. Okay, so as a form of introduction, I would like to talk about what social mobilization for health is. So it's the process of bringing together all societal and personal influences to raise awareness, let me switch this up. To raise awareness of and demand for healthcare, assist the delivery of resources and services, and cultivate sustainable individual and community involvement. Basically, all the factors and activities we have to do to improve healthcare and also sustain this healthcare. So the process is concerned with mobilizing human and financial resources through 5 main approaches, which Dr. Memo has already talked about, so I won't go through that. So basically, social mobilization requires local and international collaborations and partnerships. It's an interdisciplinary approach to achieve the required change that you expect from social mobilization. It is also the backbone for achieving the 2030 agenda of the Sustainable Development Goals. Now, the school health services is one of these interdisciplinary approaches, which can come under research and academia, and it can come under like four or five of those approaches for social mobilization. So what is school health? What's the school health program? It's a group of coordinated activities which contribute to the understanding, the maintenance and improvement of the health of the school population, promotes the development and health of the school community. The school health program is important in the overall healthcare delivery system of any country. So the school population is made up of school children, the teachers, and all other staff of the school. But the school health programs tends to revolve mainly around the teachers. Not advancing. Okay. So why is school health program important? Now we know that the school is a powerful influence in the physical, psychological, intellectual, and social development of children and young people. Students spend a huge amount of their time awake in schools. In fact, the only time they don't spend as much time is when they're at home. And then school starts usually from an early age and lasts over several years. The school is a place for early learning of health-related issues, behavior, and attitudes. And whatever these children learn in school has a high impact in communities. And we know that health problems can interfere with children's ability to come to school, the ability to stay in school or make the most of the learning opportunity they have in school. Continuing health is essential if they are to sustain these effects after the childhood. And then the school health program is an essential sequel and complement to early childcare and developing programs. So school health program is very important. WHO has said that an effective school health program can be one of the most cost-effective investments a nation can make to simultaneously improve education and health. So if you want to improve education and health, you should have a successful school health program. Now, a little about the history of the school health program in Nigeria. So SHP started in Lagos, Nigeria it was headed by Dr. Ladipo Oluwole, who was appointed to take charge of school health services in Lagos State. And this was in 1929. Then in 1952, we had our first publication of the White Paper on Public Health Policy, which covered Western states of Nigeria. And it made free medical care, care for children less than 12 years, free and mandatory. In 1995, WHO launched the Global School Health Initiative. And in 2006, the first, and I think the only national policy we're using now, the National School Health Policy in Nigeria was adopted. And this is the policy we have continued to use. So what are the objectives of the school health program? So there are 5 main objectives. The first, to detect early deviation from normal health. So in school, you should be able to assess a child and know that this child is maybe a bit deviant in some things, maybe hearing or sight. To maintain the child in an optimal state of health throughout his or her course of instruction in school, treat illnesses and restore good health promptly. The third objective is to inculcate healthy habits, which the child should maintain throughout their lifetime by their personal efforts. To teach the child to live in harmony with themselves, in harmony with their family, the community, and to submit to discipline, to respect their elders, their teachers, and others in authority over them. And then the fifth objective is to provide sufficient and accurate knowledge and information on matters concerning health and diseases for the purpose of health protection and promotion of the people's interests. So there are four main components of the health program. In some literature, you will see 3, in some you will see 6, but ideally we could go with 4 main components. So you have the school health services, health instruction, healthful school environment, and school-home community relationship. So these are the 4 main components or activities of the school health program. But when we look at our national school health policy, there are like 2 other components you can include, which are the skills-based health education and school feeding services. Now these 2 can also come under those 4 components. So I'm going to talk a bit about each of the components, the 4 components. School health services. Now the school health services are supposed to maintain the health of children, identify disabilities which can contribute to general education failures and successes. Now this school health service can be grouped into 2, which are preventive and curative services. Now the services include medical examinations. Ideally, a child should have medical examinations when they're about to enter school, midway in school, and then when they finish school. I think in Nigeria, it's mainly the entry medical exams that are done, but they should be done at 3 points or more. So the most common defects that have been identified in our children are visual and hearing impairments, stunted growth, malnutrition, dental caries, and skin diseases. Another aspect of school health service is school clinics, and it has been shown to be very cost-effective public health intervention. So these can address especially youth-related behaviors such as HIV/AIDS and teenage pregnancy. So there are 2 main levels of these school clinics. You can have that for minor ailments, where you manage the issues with first aid and sick days, which is what most of our schools have. And then you can also make provision for specialist clinics. Many schools don't have specialist clinics, and they tend to refer such children out of the school. But ideally, you should have specialist clinics within the school. Nutrition services, such as school meals and food hygiene. These aim to address the nutrition, including micronutrition deficiencies, by providing 1 balanced diet a day. So schools are expected to provide that. Some are provided free by the government, while some schools sell their meals. So it's known that children who are healthy and well-nourished will stay in school longer, will learn better, and become more productive and healthy adults. Another school health service is the control of communicable diseases, especially now in this era of coronavirus, the COVID-19. We cannot play with this aspect of school health services. So ideally, when a child has a communicable disease and in a boarding facility, that child is supposed to be isolated in the school and not sent home. But we tend to do that here because we don't have the provision. It also involves providing immunization services for the younger age group. Sometimes while in school, those immunizing maybe for polio or measles come to the school. Sometimes the school organizes for other vaccines. And then the older children, adolescents, can get their TT vaccines, tetanus toxin, while in school. Then you should provide for play activities, physical education. This is to promote mental, physical, and psychological development through healthy competition. So some examples of these include youth clubs, girls' guide, boys' brigade, and sporting activities. Then schools are expected to provide counseling, guidance, and psychological services. These all come under the school health services. Now, health instruction. This is the second component. These are well-planned and organized learning activities for the school children under the guidance and supervision of teachers or accredited health personnel. So M1 can come in as accredited health personnel to help in this aspect of health instruction. Now, this can be done through appropriate learning materials, such as what we have heard today, IEC materials, audiovisuals, to help facilitate learning. So health instructions provide health knowledge, enhance wellness, behavior, they promote health situations, facilitate healthy relationships, and responsible decision-making. Especially adolescents with their frontal lobe not well developed, they tend to make wrong decisions. So, but with health instruction, this can help to curb that. So the Nigerian health education curriculum for secondary school has 10 units which needs to be addressed in health instruction. And these are the 10 units: growth and development, food and nutrition, physical health, safety and accident prevention, prevention and control of communicable diseases, community and environmental health, family life and sex education, emotional and social health, chemicals which alter behavior, that's like substance use or abuse, and then consumer health. These 10 units are supposed to be part of health instruction and should be implemented in schools. Then you have the healthful school environment, the third component. So it involves the school environment for the physical, mental, and psychological well-being of the child. And it includes the physical environment, such as the buildings and premises, the biological environment, such as the microorganisms, the plants and animals in the school, the social environment, which deals with the relationship among the child, the teacher, or between child, teacher, child, and the environment, such as transportation, recreational services, and facilities. So ideally, there should be periodic inspections of the school environment by trained health superintendents. And these visits can be external or internal, external and internal superintendents. Environmental control requires a multidisciplinary approach, which will include the health sector, education, works and housing, and social service sectors. So what are the characteristics of a healthful school environment? Quite a number. So ideally, schools should be located away from potential hazards. The school community should be protected from excessive cold, heat, noise, and dampness. So ideally, schools should not be located in the heart of cities, which you see happening to some schools or with some schools. The requested standard for a school facility is 1 hectare of land for 500 students. Provision of adequate buildings constructed in line with approved standards. Provision of appropriate and adequate amount of furniture for the school population. Provision of an adequate number of gender-sensitive toilet facilities, at least 1 toilet per 30 students. So girls should not complain that they can't use the toilet facilities when they're on their periods. There should be adequate provision of safe water supply and sanitation facilities for the school environment, proper drainage and waste disposal facilities, safe recreational and sport activities at least 2.5 meters from a fence. There should be a perimeter fence around the school. They should observe annual school health days. There should be promotion of healthy human relationships in the school community, promotion of health-related school policies, and promotion of a maintenance culture. Children should learn to take care of property and not just say, it belongs to the government and they don't care. Switching off lights when nobody's using them, putting off taps when they're running. And then the fourth component of the school health program is the school-home community relationship. Now this deals with the coordination of child's learning and experiences in school, with that at home and in the community. It's expected that what the child learns in school should be similar to what is learned at home or practiced at home. And like I talked about, there's some other school health program concepts that are used. I've talked about the 4 main ones. I'm just going to mention these. So there's a health promoting school. This is promoted by WHO through the Global School Health Initiative. And there are 12 criteria for a health promoting school. I'm not going to read through all, but these are the 12 criteria which will, when achieved, be considered a health promoting school. So what are the characteristics of a health promoting school? It establishes and documents school policies that promote health and well-being, provides a safe, secure, clean, sustainable, conducive, and healthy physical environment for learning, builds a secure school social environment that fosters positive relationships among the school population and the community. It strengthens community links through connections and partnerships among families and the community and stakeholders. It includes action competencies for healthy living in the formal and informal curricula for development of students' knowledge and life skills, and facilitates access to healthcare and health promotion services. So most of these concepts are similar to what you have in the 4 concepts, just the way they're broken down. So some other school health program concepts, a child-friendly school. This takes a rights-based approach, and it was developed by UNICEF. And then there's the healthy psychosocial environment, which promotes a healthy social and emotional development. Which will support learning. Now, how is the administration of school health program 1? So authority over the program is with the Ministry of Health, but there's active participation with the Ministry of Education. So the school health program is actually a component of primary healthcare scheme. And all 3 tiers of government have their duties for the school health services. So the federal, state, and local government are all involved in the school health program. So the federal is involved with policy development, like we've developed national school policy for health. The state is involved more with policy and manpower development, infrastructure provision. And the local government is involved more with the day-to-day implementation and supervision of the school health program. Like I said, it's basically run as a primary healthcare scheme. And primary healthcare is mainly local government. So what are the requirements for a successful school health program? There should be good record keeping, should monitoring and evaluation taking place. There's a school health program evaluation scale which has been developed with a maximum score of 152 and a minimum acceptable score of 103. So by the time you assess the criteria used, there are quite a number of criteria, and you have a minimum, at least above the minimum score, then you have a successful school health program. You're doing good in that aspect. There should be enough manpower and intersectoral involvement. So the manpower, you have your medical officers, the nurses, the CHUs, environmental health superintendents, health educators, nutritionists, dietitians, child psychologists, and psychiatrists, the Parent Teachers Association, the teachers, and several others, the cleaners, they're all part of the intersectoral and manpower involvement. And all these people or these groups have their specific roles to play. Then of course, you must have intersectoral collaboration. If there's no collaboration, it will not work. And this collaboration should be between or among planning and establishments, environmental and sanitation, communication, agriculture, health, water, power, housing, education, transport, commerce, and industry, youth, sports and culture, social organizations, and of course the government. So there must be collaboration and cooperation among these sectors. There are also legal aspects of the school health program. So while at school, the child is the responsibility of the teacher and the school authority. So anything that happens to that child while in school, the school or the teacher needs to be held responsible. But then the child is also bound by the rules and regulations of the school. So if you commit an offense, something against the rules and the regulations, you don't expect the teachers to take responsibility. And then there could be conflict of interest arising. This could be parent, teachers, pupils, schools. As a parent, I may think that the school is not doing enough, maybe teaching my child maths. The teachers may feel my ward is not acting according to the rules and regulations, maybe it's not paying attention in class, and so we need more mediation. The school may want to increase fees arbitrarily and all that, so there could be conflict of interest. But we should always remember that it's the health and education of the child that's most important. So let's look at how Nigeria has fared over time with the school health program. I'll start with Enugu State. A study done by Onyemachi et al. In 2018, published in 2018. Now they looked at 33 schools. They used the school health program evaluation scale I talked about to assess the schools. And they found that the most common source of water was from the well. 11 schools dumped refuse openly. 3 public schools had functional toilets out of 33. 1 private school had a food service area. Only 10 schools did not have a play field. 3 public schools had soap for hand washing, only 3 out of 33. But at least all public schools were adequately ventilated and lit. That was the state in Enugu. In Oyo State, in a rural area, they assessed for 6 primary schools and looked at the quality of implementation of the school health program. And they found that about 38% of the public schools and 75.9% of the private had first aid boxes, which you say is good, but then most of them were empty. Then only 19.1% had hand washing facilities. 97% did not perform medical examination for school vendors, those that sold food. 35% of the schools had waste disposal facilities, but most of these waste disposal facilities were in the private schools. None of the schools had counseling sessions, schedules, or records of counseling sessions. So overall, the quality of implementation was rated poor in the schools, just a little bit higher or significantly higher in the private schools. And then we come to Delta State. This was a study done by our national president, Oseji and Okolo, and published in 2010. So the study was to determine the immunization and nutritional status, as well as general well-being of primary school children through pre-enrollment medical examination using 95 children. So they studied 95 children, and this was what they got from their immunization records, not good. And then the significant abnormal findings they found in the children, you can see that abdominal scarifications was the highest. 33 of the 95 children had abdominal scarifications. So the study provided a baseline for monitoring the health status of school children and evaluating several of the child survival strategies being implemented in this community. Advocacy for prevention and early treatment of malaria, improved nutrition, as well as routine immunization was highly recommended. So what are the challenges to implementing the school health program? Quite a number. The first being low priority placements from our governments, informing lack of political will. So there needs to be political will for implementation of school health program to be successful. Insufficient lobbying and advocacy. We talked about government mobilization, political mobilization. So political mobilization deals with lobbying and advocacy. So we need more of that. There's lack of quality and quantity of resources for implementation, lack of technical capacity on human resources and training. So there's incompetence, there's plain ignorance, lack of monitoring and evaluation, and of course, there will be lack of data and evidence to promote school health programs if you don't monitor or evaluate. There are cultural barriers to implementation, of course, administrative bureaucracy, and lack of coordination and collaboration among the related ministries and stakeholders. So what are the recommendations? The first will be political will. So there needs to be more lobbying and advocacy so that school health program will be brought to the front burners. Now there's a fresh approach, looking at all the components of the components, if I put it that way. There are quite a number. So in 2000, the World Health Education Forum in Dakar, Senegal, had a joint committee, which included that of UNICEF, UNESCO, WHO, and World Bank. And they came up with a fresh framework. So FRESH stands for focusing resources on effective school health, focusing resources on effective school health. Now this FRESH framework identified 4 basic components. So if a school can just work towards achieving those 4 basic components, and then if there are extra resources, they can add more, but at least work on those 4 basic components, then it could be successful. So the 4 components were health-related policy in schools that help to ensure a safe, secure physical and psychosocial environment. Nigeria has already produced a school health policy. Then have safe water and sanitation facilities. Then the third being skills-based health education. And this skills-based health education should focus on development of knowledge, attitudes, values, and life skills needed to make and act on the most appropriate and positive decisions concerning health and governance. And it should include civic education. And then the fourth being the school-based health and nutrition services. So if schools or countries can just work on providing these 4 components, these 4 basic components, the FRESH framework, then it will go a long way in achieving the school health policy. And then the third recommendation, which I think is the most, after political will, is also very important, is implementation of the National School Health Policy. Because once it's implemented, a lot of these things we're talking about, the challenges will disappear. So there are 2 main goals and 6 objectives to the National School Health Policy. So it talks about that. It also gives the implementation strategies for the National School Health Policy. And then talks about funding, how to raise money for the school health program. And then also sustainability. So if we can address all these, we will not have issues. If we can just implement our own National School Health Policy, we will not have the challenges we're talking about. Now, in as much as the school health program is very effective and is working in most developed countries, in developing countries, there are countries that have come up with their own interventions and are successful in their school health program. So we're just going to look at a few. We're going to look at Singapore. Singapore introduced the Cherish Award. Now the Cherish Award, that's championing efforts resulting in improved school health. So they give an award to a school that wins the award, and it's in recognition and to encourage these schools to establish comprehensive health promotion programs for their students and staff. So if you win the award, I mean, it goes, look at that, as Mayflower Primary School showing off the award. They won in 2012. So this was introduced in 2000, in the year 2000. Now we come to Pakistan. Pakistan introduced the school health program grants in 2003. Now what they do is that they give any school that has done at least, about 50% of the total amount they have spent for their school health promotion activities, but to a maximum of $5,000. So the school is supposed to contribute an equal amount or a higher amount. So the school brings like $5,000, the health promotion board will give them a grant of about $2,500. So this helps to encourage schools to have functioning school health programs. And then we'll look at the Philippines. The Philippines introduced the Fit for School program in 2003. And the interventions included daily supervised hand washing with soap prior to break time, daily supervised brushing with fluoride toothpaste, and then biannual deworming of all children. I remember as a child in primary school, during morning assemblies, teachers used to look at our nails and our teeth, but I don't think that's going on anymore. So the costs were comparatively low, but the benefits that they achieved from this Fit for School program was quite high. They evaluated the program and then they found out that infectious diseases such as diarrhea, respiratory infections reduced by 30 to 50%. Progression of dental caries reduced by 40 to 50%. The prevalence of helminths, parasitic worm infections, reduced by 80%. The number of children with malnutrition reduced by 20%. And then school attendance rose by 20 to 25%. So they recorded significant successes with the Fit for School program. So Nigeria has a school feeding program. This administration launched theirs, that's the National Homegrown School Feeding Program in 2017, and it aimed at feeding over 24 million children. So it was introduced to encourage enrollment and completion of school by children, to improve their nutritional and health status. Remember, it's supposed to be one balanced diet a day, to strengthen the agricultural economy. Ideally, the school feeding program should be, the food should be sourced from crops grown in that school. So the children are supposed to, and the school population are supposed to participate in growing their own food. So it strengthens the agricultural economy, or if the school can't do that, at least the local farmers, it should be sourced from the local farmers. Then create opportunities for employment in areas such as farming and catering. According to a report by UNDP in 2018, they assessed the program in a rural area, Pampaida Community School in Kaduna, and it was shown that it led to an increase in school enrollment and curbed truancy. And there was also an increase in the enrollment of girls in that community, which was known for girl-child marriages. This is a report from UNDP. So in summary, the school health program promotes the development and health of the school community. It plays an important role in the overall healthcare delivery system in any country. There are four main concepts which I've discussed: the school health services, health instruction, health school environment and school, home and community relationships. We noted a number of challenges to its implementation in the country, but then we also saw that countries were reporting successes through their innovation. So in conclusion, MWAN should be and is a major stakeholder in the school health program. Our activities have demonstrated over the years our interest in being part of the school health program. And we can be part of any of the four components or all four components of the school health program. An example of this participation will be the Menstrual Hygiene Day, which was marked by almost all the state branches last year in different schools. And to reemphasize, an effective school health program can be one of the most cost-effective investments a nation can make to simultaneously improve education and health. Thank you for listening. These are some of my references.
Thank you, Dr. Eko, for wonderful delivery. I want, on behalf of the students, thank all our lecturers. They have done so well. So we're going now to the segment of questions and answers. I'm not able to take all the questions and comments for want of time. Take as much as we can. So if we didn't call you, take offense. So if you have a question or comment, by raise of your hand, give you time. So thank you all.
To try on that. Hello. Hello. Can you hear me? Hello, good afternoon, everyone. Hello? Yeah. Can you hear me? Okay,
Yes, we
thank you
can.
for
Go on.
thank you for all the beautiful presentations. Please, my question goes to the last speaker, Dr. Heko. Please, I want to ask, is there a part of the school health
Oh,
program
Mama is calling.
that addresses the issue of children with special needs? I mean,
Mama is
is it
calling.
part of the school health program in Nigeria or in anywhere in the world? Because there are quite a number of them around, and then you wonder what could be done for them and all that. Is it part of the school health program, and what channels do we go through to get the information about such schools? Thank you.
Mm.
Did you hear my question, please?
Yes, I'm
Okay.
assuming that that we're going to pull questions.
Okay.
Or is that how we're answering? Maybe I should ask the moderator. If not, I can go ahead.
Let's take the one. Please, you can take your question.
Sorry, can I go ahead and answer? I didn't
Yes,
hear what.
yes.
Okay.
You can answer, ma'am.
So it talks about disabilities. All right. I won't say that. Well, one of the objectives of the school health program, the first objective, is to detect early deviation from normal. So this includes detecting disabilities. But the issue is, how far do we really go with our school health programs? A lot of things that are in even the policy are not implemented. So ideally, we should assess for deviation and attend to those deviations. And then if you look at the four components of the school health programs, we talked about the healthful school environment. So, and then even the instructions, the school health services, you should build a child in total, in whole. So you should take care of the psychological, their physical needs, their mental needs. So any child that has a disability, it most likely fall in one of these ones: psychological, mental, physical, and social needs. So ideally, it should, but specifically stating that for children with disabilities, this is what should be done. It's not specified. Your school health clinics are supposed to help. You should be able to refer to specialists where you need them, where there's a need. And then I was talking about the healthful school environment. So ideally, you should take into consideration the kind of buildings you have and the premises. So it should be one that children with disabilities should be able to function optimally in. But like I said, there's lack of total implementation of the school health policy. But yes, in a way, it covers children with disabilities. And then what channels to go through? The school health program, like I said, is mainly domiciled with the Ministry of Health and also with the Ministry of Education. So I would suggest that maybe you start through there. But then there are also schools that have been developed for children with disabilities, like specialists, like schools with such, let me give an example. For those who are blind, those who are deaf. So they have schools that have been developed for such children. But I know the new or the in thing is inclusiveness. So we're looking for how you can educate children with disabilities alongside with those without disabilities. And Nigeria still has a long way to go, but hopefully we'll get there, and hopefully soon. I hope I've been able to address your questions.
Yes, yes, thank you very much.
Welcome.
Thank you very much. More questions and comments? There is a question for Dr. Ibekwe. Dr. Ibekwe, ma, are you on? Says, what was communication to patients in your presentation?
It's the only God that knows.
Oh, Dr. Ibekwe, ma, are you still there? I don't think she's there. Okay. So we'll send the questions to Dr. Ibekwe. Please, if you're the one that asks questions to patients, whether it was free or sponsored by NGO, send your email so that send to her and she can give you. So nobody's raising hand for questions. Okay. So in absence of any other question or comments, I want to thank everyone for their patience. I want to thank all our M1 sisters, mentors, our mothers, my NMA brothers, and everyone that joined on behalf of our national president, Dr. Sergio. I want to especially thank lecturers for great delivery. Thank you all. But I apologize for the hitches we had and technical issues. Promise that tomorrow will be much, much better. And tomorrow's presentation is 11 a.m. looking at health data management. So once you all were really impressed with the number we have today, over 100 joined. So let's circulate this information. Tomorrow, 11 a.m. we'll be here. 5 more CM topics we handled. So thank you all for being part of the meeting all over Nigeria. God bless you. Hope we had a great time, and bye. See you tomorrow. Okay, so outside the country, America, UK, we are indeed very grateful. Tomorrow is another day. Thank you all. Thank you all.
See daddy but now. It's not daddy that say it's not me that say daddy. I want to take it back. Mm-hmm.
Don't open it though. Don't worry, I'll take my destiny.
I want to take it back.
I'll take it there, don't worry.
Take it back.
Don't take it, I'll take it today. I'll take it now. Hmm? Habit notice. Wait, one minute. We'll be done start to listen. No. I'll beat you. Put it down. Go and call that. Go and call that. No man that.
We agreed on something like that. Huh? Okay. I'm saying that the commissioner over and above the fact that the hand of it we usually get that this except grammar. But the same thing is in the new platform. It's in the ministry of it's also in the program platform. To complete. Somebody can and the population is present. Now, there are areas, but let's not find at the back of our mind. No one, no unit, no program is expected for this. But that does not mean that I have not and what they need. But what I also want to now is let us do have that. We really know about it. That's where we are. That's where we are. I think I thank you very much for having me. I get to that. So what is news approach? We all accept I don't I was never that you can do that. And fulfill your own So, please, while you go ahead to submit the next, it will be good to also attach the list of those who have been submitted.
Question officer.